University of Canada. The second lecture. So I will first the lecture will be started by Dr. Chetana Premsingh. Thank you. And I also thank our sponsors also, Lexi for sponsorship.
First of all, I would like to thank the Welisara Chest Society for giving me this opportunity. And also, I would like to thank all the consultants and my colleagues that I met during the last 2 months of training. It was a very valuable and knowledgeable experience. So, do we move this? How do we move this? Right. Fungi plays a quite important role in our day-to-day life, right? They are in the valuable, the important vital medicines we take, as well as some of the food items, and also beverages. So one might even say that fungi brings a lot of fun into our life. But today, I'm going to talk about a fungus that is not so much of a fun to have, right? So this is Aspergillus. So Aspergillus is a genus which has over 250 species, right? And they are present everywhere, indoors, outdoors, and especially when it comes to outdoor environment, they are in the decaying wood, compost piles, and among all those Aspergillus species, only about 10 species are important in our, when it comes to infections in human. And out of that, Aspergillus fumigatus is the most notorious one. And I must say this lecture could be timed better because coincidentally, the World Aspergillosis Day falls on to February 1st of February, which is a few days away. And I would like to draw your attention to the huge fungal burden in the worldwide. So if you see, there are over 6 million people every year are affected by severe fungal infections that compromise their health, even lead to life-threatening conditions, right? And out of that, invasive aspergillosis and chronic pulmonary aspergillosis are the most leading causes, right? They account for over 2 million significant incident cases globally every year. Right? Now, I would like to tell about one of the patients, right? This is a 44-year-old female patient, and 20 years back in 2004, she presented with loss of weight, loss of appetite, and occasional cough. And she underwent various investigations, and finally, she was diagnosed as having pulmonary tuberculosis, to which she took a full course of 6-month treatment. And after about a period of uneventful period, then again she presented with progressive worsening of difficulty in breathing, right? But this time in the HRCT, when she did a HRCT, there were post-TB changes as well as upper lobe cavity suggestive of an aspergilloma. She also had other investigations such as elevated serum galactomannan level, galactomannan, Aspergillus IgE, as well as total IgE. And as the investigations were suggestive of allergic bronchopulmonary aspergillosis, she was started on long-term steroid therapy. So here you can see there is a cavity in the upper lobe with an aspergilloma, a ball of fungus, or as we know, a fungal mycetoma. So, but she didn't have we couldn't say she recovered completely. again in 2024, this time she presented to the surgical unit with persistent symptoms as well as due to adverse events of long-term steroid therapy. And she undergoes extensive evaluation of her condition. And finally, the surgical team decides that she should go for a right upper lobectomy. And for that, as a pre-optimization method, she takes oral voriconazole for 6-week duration. And by the time by the time of the surgery, her galactomannan levels have also fallen down to unremarkable level. And she undergoes a right uniportal VATS upper lobectomy. Right. So here it's the histology side. So you can see there is there's a quite extensive fungal growth in the excised lesion. Right. Her post-op period was quite, I should say, quite complicated, but still she made a good recovery and went home. Right. Now she's off steroid, off antifungals, and clinically well. So that was the patient. And what I want, after the surgery, it was good. I mean, she was able to discontinue her medications, right? And a little bit about pathogenesis, right? Aspergillus species produce thousands of conidia, and they are quite easily dispersible in the environment, in the air. So we humans inhale hundreds and hundreds of these conidia on a daily basis. But they're very small, about 2 to 3 micromillimeters in diameter. So they can easily grow deep into our even as deep as terminal bronchioles. And sometimes they may even end up in alveoli, right? But if our immune system is competent, the alveolar macrophages can easily clear away these conidia, and also with the help of other immune components such as neutrophils, this infection they will not have a chance to become infective, right? But if our immune system get weakened, this conidia will start germinating and start causing troubles, right? It will the proliferation itself will cause damaging the parenchyma, as well as they will start releasing various toxins like mycotoxin, and as well as secondary metabolites, so which will further enhance the damage of lung parenchyma. And so aspergillosis, pulmonary aspergillosis is a quite rapid, it's a very diverse disease. It has a very varying spectrum. At one end of the spectrum, we have the hypersensitivity mediate clinical presentations, which we know as ABPA, right? So this the entity is quite common in patients such as asthma, cystic fibrosis. And on the other end of the spectrum, we have the invasive part, the invasive aspergillosis. This entity is occur mostly in immunocompromised patients who are on cancer therapy, chemotherapy, neutropenic patients like that. Right? And there is another category called chronic pulmonary aspergillosis. So this entity is usually more common in immunocompetent people, or in people who have only a subtle immunocompromised state. Right? So, but these are not mutually exclusive. And one of, like a patient who is in one of these categories can progress to another category if his underlying conditions can change. For example, our patient who was initially in, especially ABPA, these patients corticosteroids are indicated in these patients, but long-term, we have to take a balance. We have to take a balance between corticosteroid therapy and the antifungal therapy. Otherwise, it can progress to other entity of the disease. Okay? So it's always a balance between how we treat, right? And about chronic pulmonary aspergillosis, it is a destructive condition of the lung parenchyma caused by long-term infections of Aspergillus species. And most notably, it is caused by Aspergillus fumigatus. And among the risk factors for CPA, the number one risk factor is cavity formation following past TB infections. Right? So that is the most significant underlying condition in CPA, right? And other than that, MOT diseases and ABP and other chronic pulmonary conditions such as COPD, pneumothorax, or even lung cancer can predispose to development of CPA, right? So again, it is a whole, it's a spectrum of disease. At one end, we have simple aspergillomas and pulmonary aspergillus nodules. And on the other end, we have more destructive conditions such as chronic cavitary pulmonary aspergillosis, chronic fibrosing pulmonary aspergillosis, and these patients can even progress to sub-invasive aspergillosis with time. Right? So aspergilloma is, as I said before, commonly develops in a pre-existing lung cavity. So what happens initially is there will be, once these conidia are inhaled, and they will start colonizing colonizing this cavity. And with time, there will be continuous growth leading to formation of, significant proliferation of fungal hyphae, and they will form into a fungal ball. And also there will be other extracellular material and inflammatory material as well. So these lesions typically presents in the upper lobe, right, as a solid, round or oval intracavitary mass. And you can see a crescent of air around that fungus. So we call that it's the air crescent sign. And one characteristic feature of this lesion is that it is mobile. When you put the patient on, when you change the patient from mobile to a prone position, this ball of fungus can also change. So, but there are quite a number of consequences because of long-standing CPA. The patients can go on to developing new cavities. They can expand and coalesce and with variable thicknesses, and there can be pleural thickening with marked parenchymal destruction. And also, they can have enlargement of bronchial and non-bronchial systemic arteries, and this can cause a lot of problems with hemoptysis. So patients with CPA most commonly present with productive cough, right? Most often they have, that's the commonest symptom they have. But it is hemoptysis that brings that makes them seek medical attention. So they will also, apart from that, they will also have malaise, fatigue, shortness of breath, and other symptoms such as loss of weight and loss of appetite. Right? So this is a simple aspergilloma where you have a single cavity with a ball of fungus. And here, so there are usually the serological markers for aspergillosis is present. That is IgG is positive. And also, we may be also able to culture respiratory fluid and isolate this Aspergillus species. Right? Patients with aspergillomas do not usually have symptoms, and if at all, they will be very minimal symptoms. And they don't have progression. They don't rapidly progress. Right? But the next stage, chronic cavitary pulmonary aspergillosis. In this stage, there are more than one cavity with possibly with one or more aspergillomas, right? And here again, the serological markers are positive, and microbiological markers can also become positive, right? And most of these patients have significant amount of symptoms, and they show quite quite significant progression over time. Right? And this condition, chronic fibrosing pulmonary aspergillosis, is sort of at the end of the disease pathway. So there is significant fibrosis and fibrotic destruction of at least two lobes of the lung, complicating CPA. And these patients have severe loss of lung functions, and therefore they are quite debilitated. Right? And the other one is Aspergillus nodules. This is quite uncommon condition in CPA, right? This is there can be one or more nodules, and the problem with this is these can mimic lung cancers or carcinomas or tuberculomas. And only way to definitively diagnose them, differentiate between them is by histology. So this is another, the other condition, subacute invasive aspergillosis, which usually happens with mildly immunocompromised patients, such as diabetes patient, chronic alcohol misuses, and there is a subtle progression that occurs with about in 1 to 3 months of duration. So what I want to highlight here is that none of these conditions are mutually exclusive. There is significant overlap between each of these conditions here, and a patient in one stage of one clinical phenotype can progress to another clinical phenotype with time. So diagnosis, how are we going to diagnose CPA? Right? So first, we need to have consistent appearance on our radiological imaging, as like cavities, aspergillomas, and other features. And then we need to have a direct evidence of Aspergillus infections, such as galactomannan levels and PCR or histological or microbiological evidences. And also, also we need to have positive IgG levels. And we should always be aware of the conditions that can mimic aspergillosis, such as histoplasmosis and other endemic mycosis, though they are not very common in this part of the region. So once we make the diagnosis of CPA, we have to, what are we going to do, right? So here, management, there are two arms of management in CPA. One is the medical arm, and the other one is the surgical arm, right? When it comes to medical arm, the main goal of therapy is prevention of hemoptysis and further fibrosis, right? So we can use antifungal drugs to control this condition. So the main the drug of choice here, it's triazoles that are most commonly used. There are several triazoles, like but itraconazole and voriconazole are the most commonly used drugs, and also posaconazole. It's a quite new generation drug. It also has shown promising results. But and when we start a patient on triazole therapy, either itraconazole or voriconazole, we have to be cautious of several things. One is these drugs, there can be interaction. There are a lot of interactions with other drugs, and these, especially voriconazole, can cause derangement of liver function in patients, and also they have quite a lot of especially voriconazole has significant side effects as well. Right? So when you are starting a patient, we need to advise the patient on those aspects, and we have to monitor them properly. So this is a meta-analysis conducted by researchers, well-renowned researchers. So they have analyzed the therapeutic response between three types of triazoles as well as versus conservative management. So their conclusion is like any azole is better than no azole, right? You have to treat the condition, right? Otherwise the patient will progress to more severe conditions, right? And also they did not identify any significant differences between different types of azoles. Right. So this is another study, including a significant number of patients. How they have, however, concluded that voriconazole has better outcome with regard to long-term management of these patients. Right. And the other question is, once we start the patient on voriconazole, how long are we going to continue the therapy? There are no clear-cut recommendations or guidelines for that. So that we have to analyze on a patient-by-patient basis. Because the response to antifungals is quite slow. And some patients, most often, patients need several months of treatment to achieve appreciable treatment response. And sometimes some may not, despite that, some may develop a minimal response. In that case, it is possible to extend the antifungal duration for about up to 9 months. And even if that is failing, we have to think of other treatment modalities, right? And alternatives to trials also include IV amphotericin and echinocandins, right? And we need to monitor, once we start a patient on antifungal therapy, we need to monitor the treatment response with radiological imaging, usually at done 3 to 6 month intervals. And apart from antifungal therapy, there are other less commonly used methods, such as intracavitary instillation of antifungal medications. So this method has some potential benefit in patients who are unable to tolerate either medical therapy or surgical therapy. Right? But there are some complications such as pneumothorax and some subcutaneous emphysema associated with this condition. Right? And another treatment modality is transbronchial removal of aspergilloma. It's quite a recent technique. And the most worrisome, the condition that worries the patients most, and as us as well most, is the treatment of hemoptysis. So they can come with severe from mild hemoptysis to quite significant amount of hemoptysis. For that, if the medical therapy, medical or surgical, if the medical therapy and surgical therapy, if the medical therapy is not working, we can go for bronchial artery embolization, right? And this will relieve the condition, but it's most often, only a short time relief, and it's highly likely that patients will have recurrences. And patients who are having, who are not responding to bronchial artery embolization can go for radiotherapy as well, right? That is for who are refractory to BAE. So then the other arm of management, surgical management, right? So according to the ERS guideline on aspergillus, on management of CPA, they have recommended surgical resection of aspergilloma is the definitive treatment option for patients with pulmonary functions, right? Adequate pulmonary functions. And they also say that surgery should be considered in all patients with severe hemoptysis. So how do we prepare a patient for surgery? Now, here we are dealing with the iceberg of disease, right? So we have to be quite aware, and we have to take measures to prevent surgical post-op complications due to this fungus, such as fungal emphysema and emphysema. So for that, we usually start the patient on pre or antifungal therapy. So this pre-op therapy should start between 2 to 4 months of duration, 2 to 4 weeks prior to the surgery, right? And here again, voriconazole is the drug of choice. And if patients are unable to tolerate, we may go for itraconazole, other mold-active drug, or even for IV amphotericin, right? And apart from that, we have to do the other fungal studies, studies which are helpful in further later evaluation of the patients, as well as nutritional optimization of the patient. This is also a very important part because these patients are already they have been battling with illnesses for a long period. So their nutritional status is quite compromised. So it is this nutritional optimization is a very important part of pre-op management as well. And last but not least, we need to evaluate the risk of spillage at the surgery, right? Because if we accidentally open into the fungal cavity and spill the contents outside, so we are asking for a lot of trouble, right? There will be patient can develop severe complications of fungal sepsis. So perioperatively, we need to convert oral antifungals to IV antifungals and continue it throughout the operative period, right? And if accidental spillage occurs, there are researchers, there are studies that recommend we can try washing out of that fungal cavities with amphotericins. Right? And right after the surgery also, we have to continue an antifungal treatment depending on the patient's situation. So it is usually about 2 to 4 weeks duration. But if there is residual disease or if there is if spillage occurs during surgery, we may have to continue antifungal treatment for a long time, and also we will have to monitor these patients for a longer period, right? Right, and there are quite a lot of complications associated with aspergilloma resection. So it can range from anything from a simple minor wound surgical site infection to life-threatening conditions such as respiratory failures, pneumonia, fungal sepsis, and massive hemorrhages. So I want to ask you, with all these lot of symptoms, host of complications, would you like to have a surgery? Would you like to undergo a mycetoma resection surgery? Yeah, there's quite a lot of complications. So I think the best person to address that concern is Dr. Damika Rasnayaka, consultant thoracic surgeon. Right. I would now like to cordially invite Sir Rasnayaka sir to continue with the presentation from here. Yeah.
Thank you. Yeah, it's a good thing. Yeah, there is many complications. I know all of you are aware of these complications. The thing is that during last few decades, there were a lot of evolution around the surgery and keyhole surgery and a lot of hemostasis techniques and many development. So by using that techniques, now the aspergilloma management and fungal management has been significantly changed. It's really a tug of war between physicians and surgeons. Yeah, sometimes even our colleague physicians advise patients, surgery. That is, yes. That is mainly because of that we are not updated about the things, because that it has been really updated since last last decade. Now, the way we see about the aspergillosis or fungal disease is totally different. Correct. So basically, you all come across mycetoma. It's basically simply fungal ball. I think that Chetan explained everything. It's typically occurring any of the patient who has got previous tuberculosis cavities, chronic lung disease, pulmonary bronchiectasis, or congenital cyst. So whatever the thing is, there should be a cavity to deposit the fungus. And other thing is, it is a spectrum of disease. The patient may be, and other thing, it's a dynamic disease. When you see the patient may be in some position, but it can move to other place. It's depending on the disease nature and virulency of the organism, and on the other hand, where we manage. Because it's a mixed picture. That particularly the patient that we discussed earlier had mycetoma at the same time ABPA. The way we manage ABPA is we just load with steroid. Yeah, that is the thing. This is the way we manage. But steroid itself reduces the immunity and it pushes towards invasive part. So there's invasive component also. I will go through this thing when I discuss about that patient. So another thing is when you diagnose it, you know that it is a simple chest X-ray. You can see the mycetoma. I don't need to go through that. And as Chetana told, and this is the same one of the patients X-ray that if you clearly see, it's when you keep the patient supine, it is the fungal ball is gone down, and this is upside down. Fungal ball is freely mobile. If you do the bronchoscopy, you can see classic fungal balls. And bronchoscopy is very important to do biopsies and do fungal studies, fungal antigens, because it is very important to confirm the fungal disease prior to treatment. And sometimes even fungal disease associated with malignancies. There are also prior to resect malignancies, we have to treat fungus because and on the other hand, fungal cavities can progress into malignancies. So there are many controversies regarding optimum management about aspergilloma. That is why I thought that we won't have some kind of discussion. So I like you to have actively involved with this presentation. If you have any questions, just ask. We'll have a discussion. And other thing that if you listen carefully to the Chetana's presentation, do you know what are the limitations of non-operative management? All the antifungal drugs have many, many complications. I think most of them, you all are physicians and in medical doctors. You all know that how difficult to keep them on antifungal for at least 1 week. They come with various complications, headaches, body aches, and pain. Because on top of that, they have inherent body aches and malaise and all the problems associated with byproducts of the fungus. Their general illness, their health has a significant effect. On top of that, all these antifungal will affect. So you can't continue the treatment, and those inherent problems associated with the treatment of mycetoma. And efficacy of the treatment also depending on each case, because it's a mixed picture, as well as the virulence of organism is different. Sometimes even minor small mycetoma can cause deadly hemorrhage, deadly bleeding to massive hemoptysis. It is not the amount of bleeding is important. It is spillage into the airway and obstruction of the airway, and reaction of airway to the bleeding is the most important. And there's a study you can see, and after hemoptysis, 5-year survival is 84% for the operated patient and 41% for the non-operated patient. So we can reduce that progression of the disease by surgery, even after hemoptysis. Assume there's a patient without any problem, it's an asymptomatic mycetoma. Yes, that disease is not static, it progresses into the invasive aspergillosis or chronic cavitating pulmonary aspergillosis. So then they can bleed sometimes. And at the same time, they will lose a lot of significant amount of lung functions because it associates with lung fibrosis and cavitating and destruction of lung function. So if you get the patient initially, your treatment is easy, quicker, as well as their post-operative complications are minimum. But on the other hand, when they get the lung disrupted and get complications, and even after prolonged antifungal treatment, they can have renal failure, liver failure, and a lot of problems. So we are operating on some compromised patient. So that is why the early referral is very important. Another thing, well, if the patient is has hemoptysis, treatment that is we were talking about that asymptomatic. If there's a hemoptysis, you have to operate or manage medically. So this is the result. Inpatient mortality rate is mortality rate is lower in the patient who had the surgery significantly. It is 11.5 versus 15.1. The medical management carries very high mortality. Another thing is, when we manage surgically, they have very good post-operative outcome. That is why all the guidelines, including ERS guidelines, recommend surgery if possible for all the suitable patients. But you should know who are the patients. You have to tailor according to the patient, depending on their disease nature as well as involvement and their life expectancy and how they respond to the treatment. Not only the asymptomatic mycetoma, even chronic cavitating pulmonary aspergillosis also has significantly high evidence that surgery is beneficial. So, what are the indications for surgery? You can see here, this is open up mycetoma, the picture. You can see that this is a fungal ball, and this is lung. You can see how fibrotic the lung is. That you can see any alveolar margin here. You can see that normal cavitating, normal lung tissues, even adjoining lungs. Because thing is that it's associated with significant fibrosis and neovascularization in mycetoma. So main indication for surgery are massive hemoptysis. You need urgently have surgery to overcome that hemoptysis. And other thing is recurrent bleeding and failed conservative management. Even large asymptomatic mycetoma and persistent symptoms, maybe APPA even, associated with fungal ball. And other thing is risk of infection. And they can get bad empyema. If they rupture into the pleura, they can cause bad empyema because that empyema is deadly because it is fungal empyema. It's very difficult to treat. And they can have potential malignant transformation. And not only that, with the mycetoma, their overall health is significantly compromised. That is why they need surgery. surgery is mainly tailored according to the patient as well as involved. You can see there's a list of surgeries, generally for pulmonary mycetomas. Our aim of the surgery is to preserve as much as lung tissues, normal lung tissues and lung function. For that, we do resection from subsegmental resection, segmentectomy, lobectomy, or even pneumonectomy for the disrupted. It is depending on the disease association. But our aim is, it's like cancer surgery. We have to take out all mycetoma and contaminated tissue completely, simply called R0 resection. It is for cancers, we take all the tissues. That is what we expect. But on the other hand, there may be plural fungal disease, like empyema ruptured mycetoma. In that case, we have to do pleurectomy, decortication, and keep the pleura open into the external environment. That is called thoracostomy. And at that time, we just open the cavity and take all the mycetoma content out. That is called cavernostomy. What's this kind of asymptomatic mycetoma? As we discussed, as they can go into malignant transformation, progressive hemoptysis, and risk of secondary infection, minimal parenchymal loss. For this reason, we have to take it out. What we do is we just take a wedge for segmental resection. So it is very simple. This is very slow, I'm sorry. Yeah. So carefully see this CT scan. This is one of our patients we recently operated. This patient came with aspergilloma, and they have acute infection. So all the serology was positive, and BAL also containing aspergillus antigen. Ultimately, when we operated, it is a malignancy because there's a significant malignant transformation. Not only the malignant transformation, there were multiple pleural deposits. That is why even she was asymptomatic throughout. She had some few symptoms, but other than that, it was asymptomatic. That is why you need to consider surgery for this kind of patient because they can go into malignant transformation. On the other hand, currently the people life expectancy is increasing. Throughout the life, they can go into various drugs like immunocompromise. They can be drug-induced immunocompromise due to transplantation or some to control some disease, or they can become a diabetic. All these kind of things compromise immunity, and it will invariably convert that simple aspergilloma into a subacute or acute invasive aspergillosis. That is why these sort of patients, you have to prefer for surgical resection when they have adequate lung function, when there's a limited disease, and when they are fit for surgery. But if the disease is progressing, we need to consider for lobectomy, particularly for fibrosing aspergillosis, chronic fibrosing aspergillosis, and multiple cavity disease. There are other than that, there's another problem. When there is a fibrosing aspergillosis, that fibrosis is not because of that body reaction. It is due to the toxins produced by the fungus react with body, and body produce various cytokines and things. That is why fibrosis. That fibrosis is not limited to that particular lobe, but it may be associated to fibrosis in contralateral lung at the same time other normal lobes. So when we have lobectomy or major resection, it will significantly affect their lung function. At the same time, after lobectomy, you all know that residual lung should expand and just occupy the normal cavity, the residual cavity. But that expansion is very, very slow in mycetoma resection, following mycetoma resection. At the same time, if we spillage something into the cavity, the pleura, that is other problem. We are compromised because that there's a cavity. In that cavity, there can be anaerobic organisms develop, and there can be a lot of complications associated with that. That is why you need to consider surgical resection in very early stage than late. So on the other hand, this is disrupted lung. This is one of our patients. You can even see the name. That sorry, I didn't erase the name. So this patient came with, it's like mixed picture, chronic fibrosing aspergillosis. It was ruptured and ended up with empyema. It's nasty empyema. So this patient underwent cavanostomy and cleaning of the thoracic cavity. Following that, he had a long hospital stay, and ICU stay was very long. So that is why before that we have to do surgery. So there are many surgical challenges. One thing is the adhesion. As I told, that is one of the major challenges. Even we can't see its virgin pleural cavity sometimes. It's very difficult to go and dissect. Adhesion is the reaction to the body, to their byproducts and factors secretion. Other thing is bleeding. You can see here that's live. Why they are more propensity to have bleeding? One thing is all the factors released by the fungus react with the body, and body produce a lot of various factors which stimulate the fibrosis. That is why they can have fibrosis. Not only that, there are factors released, the angiogenic factors. These angiogenic factors can cause enlargement of normal vessels as well as microcapillary formation and large blood vessel formation, and even submucosal as well as blood pools. That pools can bleed like nothing if you just open it. On the other hand, some factors inhibit factor C. So they are having more tendency to bleed, unlike other patients. You may have realized that when you treat that hemoptysis, they don't respond to normal some anticoagulant drugs. That is the reason is their coagulation pathways totally different. You can see here that you saw that extensive adhesion resection. This is hilum. That black color is pulmonary vein, and so on top of that, this is pulmonary esophagus vein, and pulmonary artery is here, and this is superior vena cava, and you can see how much of adhesions there are around the hilum. That is a challenge. And other thing, when we do keyhole surgery, we never compress the fungal ball prior to take this vein. This vein is draining the main drainage of the segment, or that this is upper lobectomy I'm doing that for the same patient we discussed. And our main challenge is throughout this adhesion, we have to dissect without compressing the lung and get the vein. Once we get the vein, we are a bit relieved, because thing is there's minimum chance to invade the fungal debris into the systemic circulation. Then the other challenge is we can't open the cavities. Then what will happen if you open into the cavities, it will spill the fungus, not only the fungus, all these fungal ball cavities containing aerobics, anaerobics, it's a mixed colony. And if you spill it into the fungal empyema and bacterial empyema and bad wound sepsis, those are the end results. So our other thing is we should not go towards the cavity to open it into. So this is highlight resection. You can see that it is a bit difficult, but this is our life. This is what we have trained. So it is not a big challenge for us. We can do that. But I just want to show you guys how is the situation inside the lung and inside the chest. So generally, we don't need to dissect like that because that all these areas are clear. But here, my massive fibrosis. On top of that, not only the fibrosis, there are many lymph nodes. They are tightly adhered to the blood vessels because if you keep the disease forever, for a long time, there's ongoing chronic infection. That because of that ongoing chronic infection, a lot of lymph nodes develop around the hilum. Lymph nodes are around the blood vessels. So these lymph nodes make our life much difficult in dissection, and it make us tired. So that is other reason you have to think of surgery early, and it will reduce the complication. And even you can see here that some amount of bleeding. Generally, our cancer surgeries won't bleed like that, but still, after this kind of resection, only they bleed 100 ml or 50 ml like that. Even though you see this five time magnification you see here. Yeah, that is about the spillage and things. And other important thing is post-surgical complication. As Chetana highlighted, one thing is bleeding. So we take all the precautions to reduce the bleeding by this kind of micro dissection. So all the tiny blood vessels we can selectively control with this high magnification tool. That is why, because all these development happen with keyhole surgery, because we do with magnification and we control bleeding then and there. Because if you are planning for an open surgery, you can't see the backside of the chest wall. When you open the chest, you can't control. That is why that bleeding happens. But here, all around the chest we can see. At the same time, we never compress the mycetoma, so risk of fungal invasion to the bloodstream is minimum in keyhole surgery. So we can reduce the sepsis. And other thing is, we never let the cavities open generally, so we can reduce the local sepsis as well, and empyema. And other thing is persistent air leak. As I told you, one of the reasons for persistent air leak is the fibrosis. That is, you can prevent fibrosis by early referring the patients early. Then we can reduce the air leak, which is one of the key factors. Keep the patient long time in the hospital after the surgery. So if you refer early, we can discharge quickly. So we can increase the turnover. Poor lung expansion is other thing. We need to keep this patient early period more in ICU because that they are generally their oxygenations bit compromised early and more prolonged hospital stay. So that also we can reduce by early referral and early surgery. Wound infection also, I explained the theme. And as I told, our perioperative challenges, sepsis. If they develop fungal sepsis, I think mortality is very low. So other reason is we generally treat with antifungal, because high dose antifungal we can't give because it will affect the kidneys and liver, because that after this kind of surgery has significant impact on their interior, so that it has deranged their renal function and liver function. On top of that, it is very difficult to treat with antifungal. And other thing is, if you consider oral antifungal, their absorption also on top of that. That absorption also poor because our morbid mortality, gut mortality, everything has deranged. So that is one reason. And other thing I have to tell, I had few deaths in my early period. When the patient was bleeding during the surgery, I asked my anesthetist to give a little bit of diuretic acid. Yeah, that is common practice in surgery. Yes, 500 milligrams tricycle. A few patients developed deadly pulmonary embolism after surgery. They recovered well. One patient died while walking to the toilet. Other patients we detected and dead in the ward and forced did their one death at home. I think that was a pulmonary embolism. The reason is, as I told you, that all these fungal factors, fungal toxin has changed their coagulation pathway. Ultimately, on top of that, now once we take out if there's a balance, to maintain the normal balance, that these fungal things produce inhibitors as well as body will to overcome that, it has some other change. Without knowing that, we have given tranexamic acid sometime, even discharge with tranexamic acid for a few days. So then it will go towards more coagulation side. So they can get coagulation. So these kind of things you will understand by experience, and when you read around that, when you get the problems, you study that. So that is other problem. Even I thought that knowledge is very important for you all to manage even mycetoma patient with massive hemoptysis. And you don't worry about the hemoptysis generally. Massive hemoptysis is 250 ml per day. So if you manage properly, the only thing is that you have to preserve the normal lung. Keep the patient in lateral position on the affected side or the disease side. Then you can maintain the ventilation into the normal lung, and while you are treating the bleeding. So you can maintain the oxygenation, and most of the time you can save the life. And even please refer us bleeding patients, because we have managed significant number of mycetoma bleeding patients without any complications. It is not a big challenge currently because we have 24/7 on call. We can at least care of all the mycetoma bleeders in this hospital, these premises. So my key takeaways: surgical management is crucial for symptomatic pulmonary mycetomas as well as asymptomatic. And always you need individualized approach. And multidisciplinary team involvement is essential. Particularly, I have to highlight that the contribution given by our mycologists. Always, I have disturbed them even midnight, particularly Dr. Primali. She's very responsive, and every time she answers without hesitating, and they will contribute the outcome. And other thing is, we have to select the patients carefully. Assume that if there is a patient in 70s with asymptomatic mycetoma, yeah, you don't need to resect it. Yes, you can let him go without having any problem. But on the other hand, if there is a asymptomatic mycetoma in patient in 50s, 60s, you have to do that. So like that, you have to carefully select the patient who need treatment, and we tailor the treatment according to the patient factors and the disease factors. Thank you very much.
Sure, I will answer the question. There is particular treat because in part.
No, generally we treat while they are on antibiotics.